You can start.
Okay. Good evening, everybody, and welcome to this IBDENC Healthcare Stakeholders Collaboration. I am Dr. Nageshwar Reddy from AIG Hyderabad, and along with me is Dr. Rupa Banerjee and Dr. Partha Pal. This meeting today actually has an interesting origin. In fact, several years back, Dr. Rupa Banerjee had this idea that why not we get all the emerging nations together, because the IBD pattern and the way it's progressing, there's a lot of commonality, a lot of common things among all these stakeholders, and we thought we would form this IBDENC. The IBDENC has become very successful with over 30 members from different countries, everybody very actively participating, and in fact there are some very good papers that have come out of this collaboration. As we got along, we decided that this has to be strengthened further, and to strengthen it further, we realized that it has to be not only doctors coming together, but also other healthcare workers and the industry, the pharma industry also coming together to take this forward. The pharma has a lot of interest, not just for commercial reasons, but also they also are very interested in the healthcare in these patients, and also I think in terms of education and in terms of discoveries that can occur in this area. So what we decided is we decided to actually initiate a IBDENC website, and this also I think we inaugurated a few months back, which was very successful. And today what we decided is to get all our stakeholders together, all the leading members of the medical society and pharma together to a platform where we can actually initiate this. So we'll have a few, I'll give you a few introductions. This is a very open meeting, and we may want to, any of you can come in anytime, either with your comments or questions. I see all our friends there on the screen. If I can start with my first slide. First slide is on. I can't see it here on the screen. I can't see it here. Yeah, you can have the certificate, I think. So this was actually it doesn't look like a very old picture. In fact, everybody is looking the same, as young as ever. This was a meeting where all of us got together a couple of years back when the idea of IBDENC came. And you can see that this was the initial group, but later on many people joined. At that time it was a very loosely knit group, but we decided that we should make this into a more formal group. So we actually registered this group. So the IBDENC is a registered group with the Government of India. Of course, we do it at Hyderabad here, but it's the Government of India registration that we achieved. So it's a very formalized group now. So what we also decided is to make several committees, and you can see these committees that we have made, all of course with discussions with the members. There is the International Advisory Board, which consists of, I think you can see many of them are known here. Professor Simon Travis from UK, Charles Bernstein from Canada, David Rubin from USA, Professor Michael Camp from Australia, Professor Iris Doughton from Israel, Elisa Hart from UK, Sylvia Denese from Italy, Uchin Jin from Singapore, and of course Seung from Hong Kong. This is a group which I think have not only been very important as world leaders in IBD, but particularly to us, they have had the passion to see that this IBDENC starts progressing. In fact, they got very involved with this, and Dr. Rupa, in fact, is frequently in discussion with them at every step how to take this forward. So this advisory board is very important to us, and I'm glad, also thankful that all of them agreed to be on this to help us with this. Then, of course, we have the online platform that has been launched. I think this is part of today's thing, is also to show what has happened here, because once this online platform was launched, there's been a huge interest. In fact, maybe later on Rupa can talk something about this. There's several things that have come onto this. We have in the online platform, it's a little small, but if you can read carefully, you'll see that we have the mission, we have the members, we have the International Advisory Board, what all initiatives that are being taken by this group. There's going to be a section on discussions where we actually are going to discuss various things, including cases and all. Then IBD journal scan. So every week, all the important articles and journals pertaining to this, all the important IBD journals are going to be scanned, and the articles are going to be put out. Latest news in this area, some of this news may not even have come into the journals, but would have come out in other areas which will be put in. We have a patient education area where this is, of course, for patients. Rest of the things are for doctors. The patients can go in and they can get a lot of information. So it's going to be a very vibrant platform, and already there have been several hits into this, and this is going to, as we progress, this is going to become more and more important. One of the things that we have also decided is to, whatever small amount that's going to be generated from this online platform in form of advertisements from pharma, we're going to use them for, and each of this grant is going to be of $5,000. Initially, to give 4 $5,000 grants. Any member of IBD ENC can apply for this grant. I know it's not a huge amount, but it's just a seed amount that we're going to start with. And as we go along, as this ENC IBD becomes a little more, I think, richer, then probably we can increase the grants also. But right now it's $5,000 for 4 grants. Anybody can submit a project, and the project will be reviewed by a review board. And you can see in the review board, we have great people to help us. Ajay Kumar from Delhi, Ida Hilmi from Malaysia, Rakesh Kochar from Chandigarh, Shobna Bhatia from Mumbai, and Mathew Philip from Kerala, that is in Cochin. All of them are leaders again in the field, and they're going to help to review which projects can get these grants. And again, we're thankful to them for sparing their time for this. So this, I think, is going to be a very important function. As I said, as we grow along, these grants would increase, and of course would become an important part of IBDNC. And most of them, I suppose, are going to be used for epidemiological work or areas which are going to be important in terms of ENC, because this is what you're looking at, not what is already established in the West, but what's emerging from these new areas. We are also going to have, I think, a very active platform where there's going to be master classes continuously ongoing. And again, Dr. Rupa will tell you more details of this, but we have some course directors for these master classes. Again, we've chosen those who are very passionate about teaching to become these course directors. Dr. Usha Datta from Chandigarh, Dr. Jayanti and Dr. Malati from Chennai, Dr. Christopher Boy from Malaysia, Farooq Ahmed from Bangalore, from Bangladesh, Dr. Nee from Myanmar, Dr. Joe Solane from Philippines, and Dr. Pieces from Thailand. Again, all are known leaders in the field, and not only that, they have this passion for teaching, and they would be involved in master classes. I think these master classes would not only be very important for the ENC members, but all the junior doctors working in this area. I think for all of them and for the postgraduates, this would become a very important forum. We also have a case discussion expert panel, and what we're intending to do is that any of the member can put up the cases in this platform, and then we'll have an expert comment from any of our international experts, or anyone who's actually part of the member can also give their comments. But we have an expert panel also will be guiding us on this. There would be Dr. Devendra Desai from Mumbai, Dr. G.N. Ramesh from Cochin, Dr. Ujjal Podar from Lucknow, Dr. Levi C. from Malaysia, Dr. Satimai Aniwan from Thailand, Mohammad Amor from Kuwait, Dr. Murdani Abdullah from Indonesia, Neeraj Joshi from Nepal, and Dr. Munira from Qatar. Again, all leaders in the field and all very passionate about teaching in IBD, and they'll be helping us with the case discussion panel. We also going to have an IBDENC journal scan editorial board, and as I said, this is going to be an important component because these journals have to be scanned every week, and all the important articles would be distilled together and put there, so that this would become easy for those who are following. They don't have to go to individual journals. And to head this scan editorial board, we have Dr. Uday Ghoshal, who is already very well known as the editor of ISG journal from Lucknow, Dr. Ajit Sood from Ludhiana, Dr. Geeta, Dr. Anshu Srivastava, who is again a pediatrician from Lucknow, Dr. Julajak from Thailand, Masudar Rahman from Bangladesh, Dr. Tantanai from Myanmar, Vandana from Ludhiana, and Partha Pal from our institute. They'll all be working on this. And again, this is a fairly big area, as you can see. And I think you can see that we are fortunate that we have such large group of experts coming together, helping us putting this up. And I'm sure that this is going to be a huge move for us working together. Now, why this becomes important because of pharma coordination is that there are a lot of pharma who came to us saying they're very interested in working together in this platform and sharing, of course, not only their products but also their knowledge, and trying to see how this goes along. Pharma is being involved in different areas as partners for this, and already we have sponsors, the platinum, the gold and silver. In fact, they're all getting filled up. There's a lot of rush for this because pharma sees the importance on this, and we'd again welcome them. We of course encourage them to join us in this endeavor, and we believe that IBDENC is going to become a very important part of international IBD forums, and that's, as you can see it growing, it's something that's growing very rapidly. It's going to gain a lot of importance. I'd like Dr. Rupa Banerjee, who actually is the director of IBD department and also who is the initiator and founder of this IBDENC, to take over and tell us.
Thank you, Dr. Reddy, and warm welcome. I think because of COVID, we cannot meet in person, but it's still so nice to see everyone. And more than everything, I always feel that this is a group of friends working together for a common interest, and now we have IBDENC. What I thought we should focus today, since the industry is also here and all our health tech collaborators are here, is that how IBDENC can actually help all practicing gastroenterologists and physicians. So IBD is now a global disease. If you see the color, it was all white before 1960, gradually over 1980 to 2006. And now you see that the entire area of the developing world, the so-called newly industrialized regions across Africa, Middle East, and South Asia, there is an increasing incidence or an emergence. So our developing world is now all colored because of IBD, and hence we need to work together, not only for us, not only for research, but also how we can help our patients together. It is affecting the active age group. This was the data taken some years ago, but then the data remains the same. It's the active career age group where people are getting majority of the cases. The estimated burden of disease, only if you consider India, by next year, we should be nearing US in the overall burden of disease. So overall, though the incidence is less, what we are seeing is that the number, the burden will be more. And IBD is not a public health problem. There are no population-based registries. There's limited access to healthcare facilities, poor physician awareness of the disease, and confusion on diagnosis because of the prevalence of infectious diseases. There are unique challenges with IBD management. Here, I will not get into it. We know that diagnosis where TB is a major factor, inadequate patient and physician awareness resulting in diagnostic delays, poor access to and availability of basic diagnostic services, and of course, therapeutic. Again, all of you will agree with me when I say what to do when the best is unaffordable. Can we really treat to target? How do we optimize what we have? And the need for an exit strategy. Overall, I sometimes feel, and with the paper that we have all worked together, our IBD could be different, but still we do not have adequate data to formulate guidelines for the region, and I think we should work together for that. This is, as I said, who else or which place else in the world will see a colonoscopy which says query Cox, query Crohn's disease, because they are so very similar. We did a study a few years ago, and you can see diagnostic delays. Only 45% are diagnosed by 1 year. So majority are diagnosed later than a year. They go for 2 to 3 physicians before a diagnosis of Crohn's disease is made, and at least 30% have received empirical antitubercular therapy. As I said, data from this region is poor. There are very few dedicated IBD specialists. We can't expect more IBD specialists, as gastroenterologists itself is lesser compared to the more advanced nations. Dedicated IBD units are rare. There is, of course, time, manpower, and funding constraints. So there is a need of data to formulate guidelines suited to the region. So we decided that there was a need to form a common platform. In one of the IBD meetings that we have, the AIG IBD Summit few years ago, there was an opinion leaders forum. In that forum, we thought that every country presented their data, and surprisingly, the challenges, the difficulties were the same across the region. So we formed the IBD Emerging Nations Consortium, and then this picture is something we are carrying with us over time. So this is going to be with us for years together when we all got together and took this picture. So we have taken small steps ahead. We are now a registered society. We have published together as a group. Our collaborative projects, what we will discuss later today, are on. We have an international advisory board, which is a star cast of top global stalwarts. And as I always mention, overall, we are friends and enjoying working together. So this is the first study. It is still looking for a good address. We've submitted it to JCC, a multi-center cross-sectional study on IBD demographics, more than 10,000 patients across the region. It was published in DDW 2019. We presented it at DDW. So if you see here, within this, we conducted a questionnaire-based survey, and in major papers, where other international are there, you can see IBD Emerging Nations Consortium has a mention. And I think this is just the beginning. We'll soon have our own papers as well. It's a story of an emerging disease, ulcerative colitis, followed by Crohn's disease. If you see Afghanistan and Saudi Arabia, look at what we are finding. There is no Crohn's disease in Afghanistan, or almost limited. In Saudi Arabia, Crohn's disease appears to be more than ulcerative colitis. So is it that as we develop more, as there is more urbanization, we are seeing more of Crohn's disease? I think answers will come from this region. Is our IBD different? We find yes, there is more left-sided, less colectomy for ulcerative colitis, stricturing disease, less perianal disease, less biologic use, increasingly reported joint manifestations, but PSC less common. Surgery rate lower for ulcerative colitis, limited resections more common, smoking less common in Crohn's disease, familial IBD surprisingly much low, a mere 4% compared to 20% in the rest of the world. So our IBD could be different. But today, as I speak, there are additional concerns in the emerging economies. We have to think beyond us and the limited number of IBD specialists. We are a large population, and if I take India, about 70% of Indians actually live in rural areas. We published this recently in the Lancet on how difficult it is to diagnose and manage in all these low resource countries. Access to healthcare, if you see 70% of population rural, Majority do not have access to even colonoscopy. Compare that to the US, only 20% are in the rural, and in the rural, the practicing physicians are all doing colonoscopies. So it makes a difference when there is an access. We tried to study our community physicians seeing IBD, 813 physicians pre-COVID, all belonging to district and tier 2 cities. When we identified them and we carried out this survey, we found that yes, they are seeing IBD, which was a surprise. And there are many who said they were seeing between 4 to 9 cases, including follow-ups in a month. So that's not a negligible number. What is your approach to patient diagnosed with IBD? Majority said patients were not ready to travel, and they were taking care of these patients. The first line of treatment, this is where the surprise came. Majority said that for a quick response, they were giving steroids together with mesalamine. Many thought ulcerative colitis could be cured, and majority used an antibiotic for any patients with symptoms of ulcerative colitis or a relapse. And many felt that the low-dose steroids was what they were using for maintaining ulcerative colitis, maintaining remission in ulcerative colitis patients. Now, this just highlighted that there are lacunae and there are patients being seen by the practicing gastroenterologists, by the physicians, and we needed to educate or reach out to them. Do you recommend rectal therapies? Some did, some were not aware. Do you use mesalamine to maintain remission in Crohn's disease? A whopping 66% said, yes, we use it. Now, all this will have financial impacts. The correct information needs to go there. They would refer to a gastroenterologist only if no response and need for biologics. Then came the COVID. That has changed the paradigm once more and in a huge way. Regular follow-ups and travel to tertiary care centers is not possible. There is a question of drug availability. We don't know what to do about the biologics. The physicians don't know whether to start it, continue it, or what else to do for a flare-up. So managing IBD in the new normal, what we will see is that practicing gastroenterologists and physicians will now start to see more challenging cases. We did a survey of more than 1,000 patients, a direct impact of what we saw. And we inquired what happened during the lockdown and what are the difficulties that they face. 35% said they did not get any medical consultation, and only 7% could visit a doctor in person. 35%, despite having a flare, could not meet the physician. Among the patients receiving biologics, 22% missed their scheduled dose of biologics due to inability to visit the infusion center or non-availability of local infusion center with expertise. 10% almost stopped their IBD medication. So this was what was happening. So we think that this interactive web platform of more than 20 countries now, and in the last 1 month, we have more than 500 new members, 582 to be precise, a web platform not only for us who are more interested in IBD, but for all practicing gastroenterologists and physicians. So there are, as Dr. Reddy just mentioned, the personalized IBD registry for members. You can keep a record of your patients, your data, till we have a nationalized IBD registry across the region. This is the best that we can do, and we can collect data later on, and you can have your own data as well. Typical case discussions, journal scans, latest IBD news, and patient education interface. So the latest news is one-stop place for the latest IBD news, any new conference happening, and innovative news content like Twitter content. And I'm telling you, David Rubin has just put out a series of Twitters on what happens to IBD patients once the vaccine comes. Do they take it do they not? Who should take it, who should not? And this will find a place in our latest news section. We have the journal scan, all important and relevant papers updated every month. We have leaders in Dr. Uday Ghoshal, Professor Ajit Sood, and the entire team over there, the editorial board, to decide which cases or which papers should be identified. But we will plan to give more visibility to papers from the region, which may not reach a big journal, but nonetheless are important data for us. Discussing a case, any member can submit cases to be featured. The case discussion expert panel will ensure that those cases are addressed. There will be innovative infographic video depiction of the case of the week. As you can see here, I think the video is not working. Will help the patient with better treatment protocol. So any physician, even in a remote part of the country, can get an expert opinion from the top IBD expert as to what needs to be done, which patient needs to be referred, and what is the way forward. A rare side effect, we will all know. What happens with vaccination can be put up. So these are the things that will happen for this section. Then there is a patient awareness section. Health content available for members to share among their patients. Wide range of topics. Doctors can reach out to us to create health content as per their requirement as well. Later, once we are strong enough, maybe we can start a patient support group, a section in the same platform. And the IBD Masterclass, monthly educational seminar and CME by top IBD experts. Wide range of topics are being planned by our very senior and eminent course directors. I think I'll mention Dr. Jayanti here. She's training all the students for DNB, and all postgraduate fellows are her fan. So these are the people who will decide what is more relevant. There will be a challenging case of the country, once a month case, difficult case discussion, and it will rotate between different countries. So we get to know of everyone. And then Dr. Devendra Desai gave a very good suggestion. Together with the case, there will be a small cultural section from each country, so that as we know about IBD, their difficult cases, we will also know what is the culture of the country, the song of the country, and it will be a totally overall, exchange program between all the countries. So we have also now had the distinguishment to be invited to participate. I have just received these letters, and I'll share with everyone that all members, and this is a funded project called the Global IBD Visualization of Epidemiology Study, the GIVS study, and there is funding. So members who are interested can participate, and it's also linked to the IOIBD. The IOIBD wants our site to be linked to the GIVS site, so that it's a mutual benefit. We get what they are doing, the map of the whole thing, and of course they get that what is happening in IBD in this part of the world. So this is the study design. Overall, I'd just like to say that since we are here together, IBDENC.org is a collaborative effort, a collaboration between all gastroenterologists, IBD specialists, practicing gastroenterologists, and our community physicians. Together with, we should not forget mentioning the industry as well, because they also need to get out to the people what exactly is happening, education and awareness. So information at the doorstep, drugs, doses, new approach, relevant and real world data. Overall, share and learn from each other to develop the best practice strategy for IBD management in this part of the world. Thank you, and I go back to Dr. Reddy.
Thank you, Rupa, for giving us this elaborate section on what's going to happen in each area in this. Before we go to the next section, I'd like to acknowledge the presence of many leading IBD specialists, not only from our country, from SARC, from Southeast Asia, from Middle East, or actually online participating in this program. I think it's a big boost to us, to IBD ENC, that all of them are so actively involved. I'd like to thank them for sparing their time for this, because in spite of all the time zone differences that occurs, they are here with us. Now, I think as Dr. Rupa said earlier, an important component of this is the involvement of pharma, the industry in this, because this online platform is going to be very active, and I think industry is going to contribute and is going to benefit from this. So what we thought is we'd like to give this opportunity for in the pharma industry to have any comments or questions they can address, because there's a large group who's listening to them. So can we have anybody from pharma? I think Johnson is there, and
Sir, good evening, sir.
yeah, can you introduce yourself? We're not able to hear.
Could you introduce yourself?
We're getting?
Good evening, sir.
Is it Kannan?
Sir, I am Kannan here from Dr. Reddy's.
Oh, okay. Go ahead, Kannan.
Yes, sir. I just a model which happened in the UK, so that the patient care can be taken to rural India also. Are you looking something like that sort of?
Yeah. So I think this is a very important point. This that we already go through some of the pathways that have been followed earlier, and one of the pathways is what's being done in UK, where there's a huge patient involvement, not only in social media. I think it's an engagement with both the healthcare workers, with the patients among themselves as cooperative bodies, and of course the industry together. So this is something that you can look at and of course follow. Dr. Rupa, you have any? What Karan is suggesting is that all of them get together. That what's been done in UK now for IBD, because they already, I think, around 5 years ahead of us. They started long back on this. We can catch up very fast, but I think this is a good suggestion, Karan.
Thanks.
I think we have to reach the rural, at least the district and the tier 2 cities. So I think the district doctors are the ones who will benefit if we all get together, because IBD is not like the corona that there is an immediate scare. But if you come to the OPDs now, you will see that the numbers are slowly increasing and doubling, and it's the younger age group which is affected. And if we don't treat early, there is growth retardation. If we don't treat early, then there is stricturing disease, need for surgery. So I agree, Kannan. I think we have to take it to from the tertiary care centers also, the education and awareness.
Yeah, of course, we have different challenges, I think, compared to UK. For example, challenges of reaching less educated people, challenges of different languages that are not only the region, but even in our country, so many different languages, and the challenges of trying to reach all this, plus associated infective disease. So it's going to be a real challenge to how we get this across. But to start, and we have such experts as so many countries, I'm sure we'll achieve what we want to. Anybody else from pharma would want to comment, or somebody? We can't hear well.
We cannot hear you.
Okay. So I think there's some problem with the connectivity. Anyway, I think what we should do is we should go to the next session. Again, to all our pharma friends, thank you very much for being here and being a part of this. I think I'd suggest that all of you should get actively involved in this online platform, because this is going to make a major difference in our area. So we go on to the next session, and for this, to moderate these sessions, it's my pleasure to introduce Professor Ida Hilmi. Ida Hilmi is the Professor of Medicine in University of Malaya in Kuala Lumpur. She is not only a very senior gastroenterologist, but a very active worker in the field of inflammatory bowel disease. And along with her would be Dr. Mathew Phillips. Mathew Phillips is the President of the Society of GI Endoscopy of India. Again, a very senior gastroenterologist from Kerala and Cochin. So Mathew and Ida, if you can take over for the next session.
Thank you so much. I'm actually using somebody else's laptop, so that's why it says Karina on it. First of all, I wanted to congratulate Dr. Reddy for his award, the AAA, the Advancement in Science Fellowship. So Dr. Reddy, really, no one deserves it better. I read that first someone from India in the 100 years, is that right?
Yeah, thank you.
Congratulations, and congratulations to your team. Okay, so without any further ado, so I think we wanted to talk about the pediatric, introduce the pediatric initiative, right? So I was wondering if anyone from there could start the session, maybe Dr. Malati. Dr. Malati, are you there?
Malati, you have to unmute. Hi, Ida.
Good evening.
Mathew.
Yeah.
Malati.
Yes, I can speak. You can listen here now?
Yeah, now it's okay.
Yeah, good evening. Yes, I consider it a privilege to speak to you this evening. At the outset, I wish to thank Dr. Nageshwar Reddy, Dr. Rupa Banerjee, Dr. Ida, and Dr. Mathew Philip for being here and for them for initiating and to including pediatric IBD as part of the already existing IBD ENC group. Many of us who are attending this meet have attended the IBD meets organized by Dr. Rupa Banerjee under the guidance of Dr. Nageshwar Reddy. Some such excellent meetings where we've learned so much, we have met each other, we have interacted and we have shared our views. There we saw the passion in her regarding IBD. Her vision and her decision probably made her think that pediatric IBD is definitely a unique entity which should be included. I've heard Dr. Mathew Philip talking about pediatric IBD and his interest in pediatric IBD. He would always say, please include. I have so many children who are there, the adolescents growing. And we realize it's not an extrapolation of adult IBD, though 25% of total IBD are pediatrics. It's a unique entity by itself. Above the age of 6 years, though they have the classical IBD or we saw the polygenic, their phenotypes are also different. Even at that young age, they present with perianal fistula. And we know that the longer the duration of IBD, we are going to have more complications, more strictures, even malignancy. So that, I think, drives everyone. Even when adult gastroenterologists see a child, they really become upset. They feel very sad for this child. So this emotional involvement becomes more when we look at those children, because we have to put them on immunosuppressants for a long time. We are not able to give steroids. And another group less than 6 years of age also, though they are less than 4%, now we are realizing that they are more IBDU. They are not responding to conventional therapy. And many of them, those who are less than 2 years of age, we are seeing the monogenic IBD. We are now even seeing the neonatal IBD. I think it's all because of these interactive CMEs. We are coming to learn more. So I think it is, we are very happy, the IBD Society, especially of all the emerging nations group, that you have involved us. And I'm sure that this group will work together. And as Dr. Nageshwar Reddy has put forward all the programs which Dr. Rupa, I think now she's dreaming about this ENC. Every day when she speaks, she only talks about this. So we will definitely take part in this, and we will definitely do our best wherever, whatever way we can oblige and help you out. I'm sure that together, so that we have IBDENC a complete spectrum from infancy to adulthood. So that will help us to study more, especially about the pathogenesis. And I think with this, I wish the IBDENC all the best, and we are really happy that you have included us also in this group. I think Dr. Anshu will take over. I think Dr. Mathew Philip can call her also.
Dr. Anshu, are you there?
Yes, sir, I'm there. Am I audible?
Yeah, we would like to hear from you. What you
Thanks, everybody. And definitely, we are very happy because, as Dr. Malti already said, that pediatric IBD is an essential part of the adult IBD. Not means overall IBD, not just because we have unique problems in the very early onset. And recently, we completed a multi-center study from our country, and where we found that almost 19% of our children are less than 6 years of age. So that's a unique group which we need to study in detail. There are lots of diagnostic dilemmas when we are dealing with these children. We need to look after them, protection, immunization, growth. And now we have this special role of nutrition, which is coming back again after going through a 360-degree exclusive enteral nutrition support, which is helping in better healing of our children. And then a very important group is the transition, because not just for other diseases, but I think for inflammatory bowel disease overall, the transition of our children from the pediatric side to the adult side is also extremely important, because we need to have a continuation of the care. When we are involved with them over a period of 6-8 years, we have been taking care of them, and suddenly they become 18 years, 19 years, and they have to be transitioned over. That period is also extremely important so that the care is continued. And I feel that now we have a substantial number of pediatric gastroenterologists in this country who are interested in working in this area, who have now shown that we can collaborate and we can work together. And there are studies which are coming from the entire Southeast Asia in the pediatric age group. Multiple publications have come up in the last couple of years. And they have all shown that even amongst the Southeast Asians, the Indians are more at risk as compared to the Chinese and Malays. So it's not just that the entire Southeast Asia area is similar, it is different. And even in our country, the North is different from the South. So there's a very urgent need that we have data which shows how similar we are in this area, how different we are. We recognize what are our unique problems, keeping in mind our economic backgrounds, keeping in mind our social structure, and then we develop strategies to look after them. So this research is not going to come from the West, and I very strongly feel that this research is going to come from us only. So I agree full-heartedly that there is a need to collaborate in this entire region, and Rupa has taken, I think, a very good initiative, and we are all the pediatric gastroenterologists, I think I can say on their behalf that we are keen to collaborate, to work with the other pediatric gastroenterologists of this entire IBDENC group, so that we can really come up, identify our problems, prioritize them as to which one is the most important for us, and not just prioritize, but also find solutions as to how we are going to deal with it. Thank you very much for giving me a chance to speak.
Thank you, Dr. Anshu. And who else is coming now? Ida?
Yes,
Ida?
so it's, sorry. Oh, I'm muted. Am I muted? Can you hear me?
You're fine.
No, we are
Okay, all
here.
right, okay. Sorry, I'd like to introduce Dr. Geeta Mamayil. Dr. Geeta, are you here?
I'm here. Can you hear me?
Yeah, Gita.
Thank you very much, Ida, and thank you, Dr. Mathew Philip, for giving me the time. I'll be very brief. The role assigned to me is to find out what ideas have been bouncing out the pediatric gastroenterology, and just like Dr. Anshu was, we have been talking about some of the studies which we could be doing based on last meeting. So there were a lot of ideas that have been bounced out. We have not come up with anything concrete in the form of which can be done immediately, but I'll just put on a few ideas which were brought out by the group. One of them was what Dr. Anshu was saying, the role of enteral nutrition. It's been found that exclusive enteral nutrition does play a good role or a very effective role in Crohn's disease, in producing remission in Crohn's disease in pediatric population. This is implicated in adult population was something which we talked about in the last week. And they actually brought out in a study because there have been a few small studies which have been done in our group. And I think the mapping of perennial crystallized management strategies we have not done. If I could just share a couple of slides, is that possible?
Oh.
Can you see my slide?
Yeah, we are seeing.
So these are proposals sent in by the members of the pediatric IBD groups. I'm just the presenter. I'm not the owner of these ideas. So it is just to bring about some clarity. And one of the proposals that was brought about was the role of intestinal microbiome in pediatric IBD. We feel that this is an area which was discussed last time also, but it was previously discussed in our forum, on our pediatric forum also. The intestinal microbiome could be responsible for exacerbations and remissions in IBD. Manipulation of this could hold the key for better disease control. So a possibility of identifying what the intestinal microbiome in patients with IBD as compared to healthy controls is, and how this can change during flares and remissions could be an interesting study. We're not going into the details of the study, but just bouncing some ideas. If interested, then we can go ahead and do a little more research on this. Some of these have already been done by the presenters, by the persons who have brought the study. But because of the uncertainty of the finance, we have not actually approved them as yet. So just to present, the second one is very early onset IBD, like Dr. Malki was saying, less than 6 years now, we are finding more and more patients in that age group. Fairly 10 to 15% of our patients are less than 6 years. And this it's an age group where monogenic IBD is an important or a good number of these patients are monogenic IBD, and these patients need aggressive intervention. The differential diagnosis of patients in this group, however, are immunodeficiency, autoinflammatory conditions, immune dysregulation, etc., which could masquerade as IBD. Often enough, when we find granulomas or we find ulcers in the colon, we kind of label them as IBD and treat them as IBD, but it could be something else. So early segregation of whether it is going to be an immunodeficiency or an IBD is necessary for the long-term treatment and prognostication of these patients. And as we all know that genetic studies do play an important role and they are emerging in this age group. Therefore, if we could assess how much of these patients are actually very early onset IBD, how many of them are monogenic or immunodeficiency or autoinflammatory, would really benefit the IBD population so that we can have guidelines on how different the phenotype is compared to the other IBDs. So we think this is an interesting study and could be important for the future. But of course, like I said, it would involve a little bit of finances. So we have kept it in abeyance for the present. Another study which has been, with another proposal that has been brought out is assessment of bone health in adolescent IBD. We know the adolescent population is when the bone health is at the peak, and that actually determines the lifelong health of the individual. There is not found to be an increased incidence of fractures in these patients, but of course, bone health can be compromised in IBD as it is because of the disease itself, because of the treatment that is imposed on them, long-term steroids, etc., and whether the role of biologicals can actually improve the bone health in these patients. The idea was to assess the status of bone health because that's quite an unknown entity. We don't know the actual bone health of patients in our population. The status of bone health in children using vitamin D levels, calcium, phosphorus, and DEXA scan, and compare with healthy controls. So we need healthy controls for this. And also the efficacy of what we're doing for these patients right now. If we're just giving routine vitamin D or calcium in an arbitrary manner, does this really actually improve the health, the bone health of these patients? How this bone health of the patients is altered by the disease, as well as whether they can be improved or there is less effect on the bone health when you give biologicals. So these were some of the ideas that were postulated from the pediatric group. And also some of the other ideas that were brought about was the role of questionnaires. This is one area where pediatric population, the general pediatricians, they often reach out to pediatric gastroenterologists asking, how is it that you pick up patients of IBD? How is that we should suspect? Whether we can collate some questionnaires and kind of validate these questionnaires, which can be passed on to pediatricians. Like these are the tick points, or these are the alarm signs, which if you see in patients should alert you or should make you refer them to a pediatric gastroenterologist for further evaluation. That could be an area where we could develop such questionnaires which could benefit resource poor countries, where not everybody should go, but at least some of these patients should. So with that, I would like to end my talk, and I would thank you for the patient listening. Over to Dr. Mathew Philip.
Yeah, thank you, Dr. Geeta, for the nice presentation. And Ida, are you there?
Yes, I'm here.
Can I just follow up on Dr. Lee now?
Yeah, so I want to give me pleasure to introduce Dr. Lee. He's a colleague I work very closely with from University of Malaya. Waistia, Dr. Lee Waistia, would you want to say something? Are you around?
I think Professor Lee has.
Oh yes.
Yeah.
Sorry,
So
I forgot.
Professor
Ng is going in his place. I forgot.
Yes.
Ng, are you around? RT? Prof. Ng, Professor Ng. Because he had some problem.
Hi.
There you are. Sorry, RT, I forgot. Yeah. Okay.
Sorry. Thank you, Prof. Ida, for hi. I'm Ray from pediatric gastroenterologist in University of Malaya. I work very closely with Professor Lee and Prof. Ida. Thank you for bringing me into this consortium. I have a great pleasure of it. Sorry, because things are I was joining a little bit last minute, so I didn't really prepare any slides, but I just want to quickly share some challenges that we have come across when managing pediatric IBDs. As per the previous few presenters has rightfully pointed out, diagnosis of pediatric IBD has been always a great challenge among our children. It's very common that we see delay referrals about these problems, and our patients might carry the disease for months and years. The longest I think I can remember is a child with ulcerative colitis who has carried the problem for 6 years. 6 years with the daily about 10 times of diarrhea, including nocturnal diarrheas and repeated blood transfusions, and severe failure to thrive, and as well as I think very poor bone health, right? So I mean, this child has seen many doctors for such problems, and yet at some point, I would say suspicions for this IBD has brought up, but unfortunately it wasn't pursued further. So this child continued to carry this problem. You can imagine a child who is, when he come to us, he was about 10 or 11. So 6 years ago, that means he was just about 4. So he has carried this problem with him all this year, along the important years of his thriving and development. And thank goodness, he, despite of all this poor physical health, as well as this poor quality of life, he continued to do reasonably well in the study. That was, I've been very, very grateful, and I really give this huge credit to the parents who are dedicated. And I thank you for the state pediatrician, one of the state pediatricians who finally recognized this problem and pick up the phone and give us a call. And when we saw this child, everybody got a shock. How can this child carry this problem for the past 6 years? before he received any proper treatments. So as you can see, yeah, this is always a problem. And again, we also have problems where children are diagnosed as a TB gut and then turn out to be IBD. Of course, on the other way around, we also have patients who are diagnosed to have IBD and given steroids and even biologics, then turn out to be intestinal TB, and because of all the interventions, has complicated further with systemic TB and with significant morbidity and mortality because of that. So it's always a huge challenge between the diagnosis of IBD and Crohn's disease and IBD and TB. Yes, recognize that. And then about this very early onset IBDs, those of monogenic disease, we also see that, and we agree with the previous presenter that this is a huge challenge. It's a group with huge challenge because they don't respond to conventional therapies. We have a pair of siblings who have this XIAP deficiencies, and they needed a bone marrow transplant. And at the moment, we have another one who has autoimmune myeloproliferative disorder when he's younger, during his younger age, and now he has this very refractory Crohn's-like disease where he's not really responding to anything, but we couldn't find any mutations for him for the moment. So treatment, it remains a huge challenge despite we give him up to nearly 15 milligrams per kilo of infliximab at 4 weekly kind of treatments. He still just barely maintain his near normal kind of quality of life. So we do have a huge number of pediatrics patients because I think the problem in our country is we do not have a universal whole country kind of registry for IBDs. Our data is just mainly limited to our own center, University Malaya, which is a teaching hospital and one of the tertiary centers who has pediatric gastroenterology service. So we have about 100 of us. So I think our numbers do not represent those in the whole countries. We are not very sure how many other children are out there undiagnosed, and all others are managed in our counterparts in the different state and district hospitals. So yeah, I think it's a huge pleasure to join this group so that we can learn, because we are in the same region, so we will face the common problems. I think this collaboration will be very, very meaningful to this group of very unfortunate children. Thank you.
Thank you, Dr. Roy.
Thank you.
I think now we need to move to the next person. Dr. Ida, would like to invite.
From Myanmar, I think.
Can you?
Dr. Hin?
Yes.
Hello.
Hi.
Yes.
Good evening, everyone. Nice to meet you all. I'm so glad and proud of become a member of IBDENC. I'm Dr. Nim from Myanmar, working as a consultant pediatrician specialized in pediatric gastroenterology. I would like to say many thanks to Professor Nguyen for giving me these great opportunities to get involved in this IBDENC workshop as a Myanmar representative in Pediatric Chapter Introduction. And then many thanks to my Professor Theda for attending this workshop today. As you all know, the incidence of pediatric IBD appears to be rising both in industrialized and developing countries. Also in Myanmar, pediatric IBD cases are on the rising trend, and so this is a real problem. Incidence has been estimated as 2 to 4 cases per year in Myanmar. Most of them are ulcerative colitis. I have been handling pediatric IBD cases in Mandalay since February 2020. However, there was still a positive of epidemiological data on pediatric IBD in Asia, especially in Myanmar. So the true disease burden is difficult to estimate due to the lack of national disease registries. I hope I can learn and discuss about the case management for our pediatric IBD patients in the future. Thank you.
Thank you, Dr. Rupa. Ida, we have some time for questions and comments.
Dr. Philip,
Ida?
we'll
Yeah.
have the whole, we have a large number of people. So we'll just go into the thing, and then anybody regarding any projects or budget questions and other things. And I'd also take this opportunity to tell you before the end that January we are planning a big global, first time ever, a global pediatric platform and conference for IBD. So it was scheduled for April this year, but we all know what happened. So it's 2022 January right now. And till that time, let us keep up the good work.
Okay.
Over to you, Ida.
Yeah, I'm afraid I'm going to take my leave now, actually. I'm really sorry. Matthew, if you don't mind, have you got the list of
Yeah, I know that.
The presenters? Yeah. Okay, so I'm sorry, I've overbooked myself, but I think I'll leave Dr. Phillips to present all the projects that we
Okay, thank you, Ida. I think Rupa can join me during that time. And we have now the session 3, and we have Dr. Partha Pal to introduce the project by 1 or 2 slides each. After that, we have Uday Ghoshal. Rupa, are you there?
Yes, I'm there. I'm there, Dr.
Yeah, so you can replace Ida for time being. Ida, bye. Thanks a lot.
Ida, thanks for being here. I understand we will just meet at the next meeting.
Dr. Partha?
Yes, sir.
Can go ahead. 2 slides.
Yes. Good evening, everyone. Today we will discuss the current project dashboard of IBDENC. So we have received many projects in the last 2 meetings. Among them, 6 were presented in detail, and many others were discussed. And I shall just touch upon them once. First one is from SDPGI, but Dr. UC Ghoshal. That was the frequency of coronavirus infection and its outcome and the predictors among patients with IBD in emerging economy. Second one was by Professor Ajit, the evaluation of nutritional status in IBD and its correlation with disease scores. Third one is by Professor Mohammad Omar, that on IBD among 2 different groups of expatriates, that is Egyptians and Indians living in Gulf countries, population-based prospective study. Fourth one by Professor Usha Datta from PGI Chandigarh, which was on vitamin D deficiency in IBD, prevalence and relation to disease activity, severity and extent. Then by Dr. Masudur Rahman from Bangladesh on prevalence and risk factors of GI infections among patients with active ulcerative colitis. And from our center, the study of evaluation of psychosocial impact of IBD in patients and caregivers in the developing world, and IBDENC initiative. So there are several other projects that were discussed but not in detail. One was from by Professor Tantan Ai on gut microbiome status in patients with ulcerative colitis in Myanmar. One by Professor Mudani Abdullah from Indonesia to study to determine the role of infection in our IBD from our region with a poor sanitation and malnutrition. By Professor Jayanti on small bowel Crohn's disease, role of various modalities of investigation to confirm isolated small bowel Crohn's and surveillance of small bowel Crohn's disease for adenocarcinoma. Dr. Devendra Desai has come out with many projects. So these are on socioeconomic status, diagnostic delay, adherence to therapy, barriers to local topical therapy in ulcerative colitis, and acute severe ulcerative colitis management. Dr. Mathew Philip has also proposed 2 topics, that is one on NUD15 genotyping in emerging nations. We had a recent paper on this from India, and genetic mutations in IBD, Crohn's disease in emerging countries. Dr. Nuni has told about vitamin D and UC using short colitis clinical activity index, and also other studies on UC or based on serum NGAL levels, procalcitonin levels, and other serum trefoil factor 3. Madhuri Nilinala from Sri Lanka has proposed a study that to conduct a genome-wide association study collecting more than 5,000 South Asian IBD patients as a part of IBDENC. So the first one is frequency of coronavirus COVID-19 and its outcome and their predictors among patients with IBD in emerging economic countries. The basic of the study is that in that IBD and non-IBD controls will be evaluated for risk factors of SARS-CoV-2, that is history of contact, travel to endemic area, symptoms of COVID-19 will be evaluated, and the diagnosis will be done by RT-PCR. And in patients with COVID-19, severity assessment, mild, moderate, severe or critical based on oxygen requirement, pneumonia and ventilator requirement, and their outcomes will be studied. So I keep this first project open for discussion.
So I think I will ask the first question. Dr. Uday, many countries are seeing lesser number of COVID patients now. And that is a concern that many have written in the letter as well, that because COVID is coming down, is it worthwhile having this study now? So your comments on the same. Dr. Uday, are you there?
Yes.
COVID disappears, will be very happy. Let COVID disappear from the world and let this study fail. Will be very happy. Will be the happiest person. But what happens is, practically speaking, it is scientifically unlikely to happen. Those countries which are not seeing it now, obviously, as they try to become normal as per old standard, it is going to come back. So what I'm saying is, also because we do not require a very huge sample size, even the small number will do the job. So in fact, now one of our paper is under evaluation in JGH Open. See, this is a paper only on 55 patients, only on 55 patients of IBD. And now this we submitted initially to JGH, not hoping that it will get into JGH, but hoping let it be transferred to JGH Open. Then there will be $2,000 saving, you know. So what happens is it was quickly transferred in 3 days to JGH Open. So it tells you even a small number of patients will do the job. It is a very easily done.
Would you take any other comments from anybody else?
Yeah, surely.
So would you take retrospective cases as well? People who have already had?
Yeah, if it is done as per protocol, we can take, but it is unlikely it will be done as per protocol, the retrospective cases, because we are not saying that we want COVID-19 patient in IBD. We are saying if you have an IBD patient, we want to study them. Are they following the sort of preventive measures? And did they get COVID-19? So what I'm saying is, in retrospective, I don't think you will have all those parameters. We will not typically take retrospective, but we want IBD patient. Like suppose, let us say in one country, let us say Sri Lanka, they give me 50 or 100 IBD patient and non-developed COVID-19, that will be very good. In fact, in our SGPGI, only 2 patients of IBD developed COVID-19. And we see on an average, maybe even in spite of this lockdown, by this remote technology, we see almost 40 patients a month. But we have
Yes,
Dr. Uday,
yeah.
Can I ask you a question? After that, we'll ask question from Mohammed also. See, 55 numbers, a properly worked up IBD COVID is not a bad number. It's an excellent number. And another thing is now, when we actually collect data from different areas, from, for example, ENC countries, what is your expectation? What is your aim of the sample size? What is your aim? How many numbers?
Yeah, you see, I will not fix up an aim or a number for a country. The reason is that we want IBD patients. We don't want IBD with COVID. We want only IBD patients. Now, what happens is the countryside will determine how many they can give. But I'll be happy if they give 50 to 100 patients each country. But because they could not fulfill this number, we'll not remove them. They are very important.
Okay. Dr. Omar, Dr. Mahmoud Omar, your comment?
Hi, everybody. I want to say that still visible. I agree with my colleague. It's still visible. I think we should go for it. Many countries are now in the second wave, especially, for example, like in Egypt, numbers are going back up again since December, end of November, beginning of December. So it's still visible. I think we should go for it.
Okay, thank you, Mahmoud.
Thank you.
Go to the next.
Any other questions? Shall we go to the next?
One.
Partha?
Yeah, yes, sir.
So I think before you go to the next study with Professor Sood, I'd also like to say that other studies initially whom we actually kept aside because of financial constraints, we have a little bit of grants now. So I think if anybody can send in their proformas, we can actually look into it. And 4 projects, interesting ones, maybe microbiome ones, we can perhaps think of it. At least a submission can be done. Over to you.
Yeah. The second one is on the evaluation of nutritional status in IBD and its correlation with disease course, observational multi-center study. Maximum number of members actually wanted to participate in this study, and this was on the prevalence of malnutrition and sarcopenia and correlation between malnutrition and disease course, to identify different values of malnutrition and sarcopenia in Indian population, and to identify a nutritional plan was the different aims of the study. And IBD patients, both in active patients and remission, as well as healthy controls, will be taken. And these are the logistics that has to be done. The proforma has to be filled up on a clinical history, anthropometry, specifically BMI and mid-upper arm circumference has to be done. Nutritional screening in the OPD has to be done by MAST or MART, or in the inpatient department has to be done by NRS 2002 questionnaire, and this sarcopenia will be assessed by L3 skeletal muscle index or hand grip strength dynamometer. Investigations are also simple: complete blood count, peripheral blood smear, iron studies, albumin and calcium, magnesium, vitamin D, and clinical activities like Mayo score, UCI score for endoscopic index, and composite scores like CDI score, and for Crohn's, the SES as Crohn's disease score for endoscopic index, and fecal calprotectin and CRP, these inflammatory markers will be assessed. So seems to a doable study. So I keep the house open for the questions. The study.
Dr. Sood is there?
Dr. Sood, are you there? He was in the ICU a while ago. He said he'd try to join.
I want to make a comment. I think, nutrition and IBD is really a very important area which needs to be studied further. And we know that diet or nutrition, either diet is a factor for causing IBD. Nutrition can be a significant factor for worsening of their symptoms. And also in children, I think, that pediatric group is there. I think, nutrition becomes more important in pediatric growth. And and the last thing is nutritional therapies. There are so many therapies actually now where we can use nutritional alteration or changes, or using a certain type of feed, whether they can benefit by treatment as such. And I think nutrition is a very important area, and it is actually underestimated that we do not look at our patients, IBD patients, about their nutrition status. I think once recently I gave a little more importance to nutrition. I changed their diet and started giving them different type of food. I found there is a significant benefit. Even those patients who are not responding, when we give some not purely enteral nutrition, but not exclusive enteral nutrition, but at least I add on an enteral nutrition, I think there is some change on that. So Rupa, you can comment or comment from anybody else.
Dr. Mathew, can I?
Yeah.
Your point is well taken. Now, actually, there's I'm Anshu actually.
Anshu, okay.
Yeah. Apart from exclusive enteral nutrition, even just the dietary modifications, recent studies have shown that even in patients who are not responding to biologicals now, they are showing that they can help us in that scenario as an additional therapy also. My only concern with this assessment of sarcopenia is this cross-sectional T3 level muscle mass, because the standards are available for the Western population, at least for adults. I'm not talking of children, but they are very much different as compared to our population. So I just wanted to make sure whether we have the Indian population cutoffs with which we are going to compare the sarcopenia muscle mass assessment for this study.
I think it's a very valid point, and I think we should actually work on that, and we should have a reference for that particular thing. And as you told that some patients who were on IBD with the biological response inadequate. In fact, some of my patients who are actually biologicals, but they were not getting adequate response, when I modified their diet, when I added some enteral nutrition to them, they actually responded.
Yeah, that's very good. It works very well.
Can I, Dr. Usha? Yes.
Yeah.
Dr. Usha.
A quick comment on sarcopenia normal data from India. A recent study by Sandeep Sidhu in cirrhotics versus non-cirrhotics. He had a sarcopenia assessment using this L3 CT scan. So there is normative data from India on this issue.
Thank you, Usha. Do you have any information about any pediatric data also? Because I'm not aware that there's pediatric normative data from our country.
Dr. Anshu, I think from our radiology colleagues, if we look at them, we can easily get this data. Should not be difficult.
No, yeah, that I agree. We are working on it and we are trying to collect it. But I just wanted to know if you are aware of any published data.
No, I'm sorry. No.
Thank you.
Any more comments, questions?
Yeah. Dr. Mathew Philip, I'm Dr. Masood Rahman from Bangladesh. May I ask a question?
Hi, nice.
Regarding the participations in the nutritional status study, what should be the minimum number of sample size to participate from a particular country center?
I think
Ajit has to answer that.
I think what we should do is we will have Dr. Ajit give a thing, but for India, Bangladesh, Sri Lanka, this region, we can combine it together as South Asia. So the numbers, I think, will have to be large because small numbers will not make a difference. Any comments from Dr. Desai? Are you here?
Yes.
I can see Julajak. Julajak, you want to make a comment? You wanted to participate in this study, so I just wanted to ask you. You're muted.
Yes, because I think this important issue for taking care of IBD patients, and I think if we have more patients data and so we will get a valid results, and that could help my patients in the future too. So that's why I would like to participate in this study. And for the parameters that you will measure, I think we will, if this study will start, we will know about the definition of those parameters in detail, right?
I think Dr. Shobna, you want to add a little bit?
Yeah, so Rupa, we also were looking at participating in this study, and this is a very interesting concept about diet and IBD. The thing is, just like Usha said, the sarcopenia data are available for cirrhotics, but in general, sarcopenia data for adults on an all-India basis are really not available. So that might be an interesting aspect of this study, that we could collate this and have some data from there. If you're looking at some normals, then you can get more sarcopenia data for normals as well.
Excuse me, I'm Rani.
Yes, tell me.
Yeah, So we are we also interested in the nutrition and IBD data. We don't have sarcopenia for normal sarcopenia data for the normal patient of the Myanmar population, but we try to arrange for that, and we are really interested to participate in this study.
Yeah.
Okay.
So what we are going to do is that there's a large interest in this study, and since Dr. Sood, I gather he might join in, but he's still not in. We will be having a separate group meeting for each study now, such that the decision can be taken. But at the same time, I'd like to ask everyone, and I think Usha and Devendra, Dr. Desai, are you here? Devendra Desai?
Yes, yes. Yeah.
I would like to know that what will happen. I think all the stalwarts are here. I can see Dr. What will happen about the ethics committee permission? So, like for each of these studies, will individual centers have to take individual ethics committee, or should a central, like, if we can act as the secretariat, take an ethics committee approval and circulate it? Some countries, will it allow that?
Can I come in here, Rupa? Can I come in here?
Yeah, Usha, tell.
Just a couple of things. Starting with the ethics issue, ethics has to be taken by each of the centers as a part of a collaborative study. So recently I took ethics for our previous studies for various collaborative things. So what we usually do is one center gets its ethics done, and then showing that ethical approval, all other centers get their ethical approval done in their local centers. That is point number one. Point number two, how many cases should a center have, for participating in this whole exercise? I think if everybody endeavors, it will be very easy to get minimum 50 cases from each center. I think that many IBD patients.
I completely agree. Yes.
Yes.
People can easily go up to 200, 400, but I think we should have a minimum number of everybody trying to get minimum 50 patients in a 1-year recruitment period. And the third issue is, as far as possible, if we have simple investigations to do, or just take a sera and keep it aside, or just some simple clinical parameters, it would be easier for everybody to participate. We can make it as a single ethical approval statement saying that these things will be done in the patients, rather than make them into multiple subset studies and take a single ethical approval, because to have 6 ethical approvals or 6 different studies will all become practically difficult, because most of the studies are very simple. So let us keep the studies simple, have more people participating under a single ethical approval banner.
I think this is a wonderful suggestion. Any comments from anyone else? Usha, this is
Rupa,
yeah.
Rupa, I just want to ask, say, Usha, this is actually not only one country. We have actually many countries. So an ethical agreement or consent from one country may not be applicable to another country.
Yes, I am.
Can the admin mute those people who are not talking?
মানে ওই মিল্ক ল্যাটের প্যাটার্নটা আমি বলেছি আগে গ্রোথটা বাড়িয়ে নিই তারপরে
Can the admin mute those who are not speaking, please?
Yeah, can you mute your phones if you're not speaking?
Yes, coming here to what Dr. Philip raised, this issue, it's very important. I have been in close collaboration with our own ethical committees, and I've realized the way they function is, if you make one project and get an approval from one particular center, then showing that to all other centers with local modifications depending on how their ethical committees run, then it gets facilitated across everything. So AIG can take the lead and get its ethics done. I can take a lead and get it done at PGI. And then using these kind of ethical approvals, then everybody can get it done at their own local centers.
Even outside India, that's what I want to do.
No.
Yes. That's the problem.
Dr. Philip, I think everybody would have their own way their ethical committees run. So we can just show that our ethical committee has approved, their ethical committee may not approve. So the more simple we keep it, the easier it will become.
Can I just comment on this one?
Yeah.
Yes, please.
Yeah, I'm Dr. Vishnu, gastroenterologist. I agree with Dr. Usha. Actually, what she's trying to say is we should have one ethical approval wherever the center is going to lead, and then that could be modified by each center. I think we should keep it like that. Although each country will have a different ethical committee, different norms, and etc., etc.
I think we have people from every country. Pise, are you still there? Pise, Thailand?
Meanwhile, I think Rupa, Devendra was trying to say something, we will listen to that.
Yes, yes. Pise, we want your comment and then Dr. Devendra Desai. Pise, I think you're muted. Yes.
Oh, okay.
So nice to see you. So what do you think about ethics committee permission for these simple studies?
Yes, I think it's very useful, and most of the site can do the investigation on their own, so it's not very much expensive.
Okay, great. So another country, before I go to Dr. Devendra Desai, Dr. Philip, do you think we can ask Dr. Omar, because he'll have
Yes. Dr. Omar?
Yeah, I think it can be done. I'd like the idea of having one approval for all the studies as a one big project. But I think it can be done, yes. It is simple. The simplest, the better,
Yeah. So, Dr. Devendra, your final comments on this? Then we will move to the next.
Everybody has already said that we need individual center ethical committee approval. My only thing is, do we need to do a CT scan in all these patients where we are talking about sarcopenia?
Pardon? Question is?
Assessment of sarcopenia, do we need to do a CT scan?
Other option is that dynamometer can be done. That hand grip.
Yes, sir.
I have a comment here. You see, different ethics committee and different country may work in different. But what happens is usual standard ethics committee like in LGPGI we have, and at least developed country ethics committee will have. They will want to club all the projects into one. If they are very related projects, they will give up. Yes, very related. If they are totally unrelated, it is unlikely that you will get an approval for 5 studies totally unrelated. And typically, ethics committee member looks at the cost. If they find we are doing a lot of things which are not necessary, and there is no funding agreement for this, they will be worried because they will say maybe patient will pay for these tests, and therefore they will not give. So this is the standard system. We know there are some ethics committees which are quite maybe loose. That's fine. It makes the investigators' life easy, but at least in LGPGI, it's impossible.
I agree. I think this is, what we'll do is, as per what Dr. Usha said, we will take some ethics committee approval, and then maybe individual members can write to us as to what they need for their countries. We will be providing the documents accordingly. Together.
Then can we move to the next one?
Yes.
Yes. And before I go to the next one, I'd like to say that we have colleagues from Vietnam who have joined in. I cannot see all of them, but for the next project, a lot of them have shown interest in doing it. So we would want their comments as well.
Yeah, it's very interesting to see them and hear them. Very good.
Yes. So there's a big team from Vietnam, including their pediatric gastroenterologists who are also part of the membership now. So I think we'll take their comments as well.
So the third study is IBD among 2 different groups of expatriates, that is Egyptians and Indians. Can you show my slide?
Yes, we can.
So, living in Gulf countries, a population-based prospective study by Professor Mohammad Omar from Qatar, that Egyptians and Indians at expatriates as well as nationals, either adults or children living in geographically defined areas of six Gulf countries and diagnosed as IBD in the last 1 year of the project will be included in this study. And the demographics, disease course, laboratory features, endoscopic findings and therapy data will be collected at enrollment and every 3 months for 2 years. And cases will be followed up for 2 to 3 years of the project. Asymptomatic Egyptians, Indians and Gulf nationals will be randomly selected as controls. Another age and gender matched group of homeland controls will be selected from matched areas in Egypt and India. Different environmental factors like diet, smoking, psychological stress, medications, previous infections, antibiotic use, vaccinations, surgeries like appendectomy, exposure to different animals, etc. will be assessed in separate validated questionnaire. So I keep this project for discussion. Open for
Dr. Mohammed Omar, are you there? Dr. Omar?
Yes, I'm here.
I just want to ask you a question. Is there 3 groups now? The expatriates of 2 groups and the nationals. So you are going to compare between the 2 expatriates versus the nationals. Am I right?
Yes.
Then you also told that you are taking controls from their own countries. Now, how is that?
The control from all countries through our Egyptian and Indian colleagues, because this another control group will give an idea about the real environment for the expatriates. The point in this project in particular, although it is a kind of immigration or immigrant study, but it's different from the usually published studies, is that the expatriates are not a real immigrant. They still keep in contact with their own countries, with their homelands, and they're still going back and forth between a well-developed country, rich country, a well-westernized country like Kuwait or Gulf countries, and their homelands, at least for 2 to 3 months during the summer. So this might affect this. What I'm going to study is, I propose to study is, they are not a real immigrant as other published studies. Those who leave their own countries, live completely in an industrialized country, but still have some contact with their own homelands every year for 1 or 2 months.
No, Dr. Omar, it's actually a good idea, but I have a strong feeling that the people expatriates are actually not, as I told you, they are not immigrants. They don't migrate to a country. And there are people actually, population, especially people work in rigs or oil field. They actually come every 6 weeks or 8 weeks. They come to their homeland. Am I right? So there's a group of population like that.
Yeah, but I don't think we should include these people. We should include the study aimed at including those who are living, the families are living in the country for years, and those who are not only the first generation, but also the second generation who are born in the Gulf countries. And these are very important and can be a part of that with our pediatric colleagues, also pediatric GI colleagues. Because what I'm seeing now in Kuwait is that increasing number in the second generation, those who are born in the country, in Gulf countries.
I think this will be a very interesting paper because they have shown the same in Canada. That, second generation, it's higher. And if we can show it in a small area in the Middle East also, that will be a much cited paper later on when we look at publications. I think Dr. Yogesh is there. Yogesh Shastri? Dr. Yogesh?
Yes, ma'am.
Your comments on this?
Yes, it's really very interesting thing. I agree with it that
because Yogesh is based out of UAE.
So we are also finding it that when we see this second generation or people who are staying here for longer, the incidence is different than their home country or their base. So we can also be a part of this because we have similar patient demographics what is there in Kuwait, and we have a lot of Indian expats as well as Egyptian and other expats. So yes, we can really see that this study is feasible and it will give us much more information.
Dr. Usha, you want to make any comment? Yes.
May I add may I add something best before?
Yeah.
As I discussed with Rupa over the email, it can be expanded also to Filipinos, to Bangladesh.
Yeah, exactly.
These are a large group of expats from these countries. So I started by Egyptian and Indian because these are the two major groups.
I think from Bangladesh
But we can expand to any.
From Bangladesh, we have Dr. Hassan over here, Dr. Mahmood Hassan. Sir, are you?
Yes.
Yes, your
Yes, I'm
comments,
here.
I think, for this study, it will be.
Yes, my comment is that I don't think we really have second generation Bangladeshis, but we have first generation. So they can be included, and I think that will be a fairly good number. Although I don't know how many IBDs will be found, but certainly the number of people there are very large. So this is a good proposal.
Usha?
There was a paper in gastroenterology which looked at the first and second generation Indian immigrants to USA and their incidence of IBD, and they concluded that the second generation immigrants had higher incidence of IBD because of the dietary pattern. So this is a very good interface to study between first generation and second generation, because infection goes down, but the diet changes. So this effect of each of these components can be studied in Dr. Omar's study, and we can look at these two components. So interesting.
Yeah. Usha, there was a study from Jayanti long time back.
I was about to say that.
UK. In UK also, she had studied
Dr.
at
Jayanti, are you there?
Jayanti, comment on that. Your South study, it's actually very.
That's one of the first studies on the same.
Very widely quoted study also that.
You can hear me?
Yes, a little louder, ma'am.
Yeah, I think the laptop is a little weak. So we did the first generation study, and subsequently after I finished that study, the second and third generations were also studied. And they came out with the same information, that the prevalence is similar to the indigenous population, the second and third. Okay, so I think, it's already well established that once they go for a second and third generation study, that the prevalence is almost similar to what is there in the indigenous population. So
I think we need your inputs for this paper.
In each of the populations, yeah.
So maybe the protocol, and we have the subgroup meeting on this paper, then we will take your expertise to help us to decide what has to be done.
Yeah. Omar wants to say something more?
No, I want to just emphasize what I said before, is that this group in particular will be different because, as I said, they are not totally immigrant in a sense that they are leaving their country. Like those who are going to Canada or the States, maybe they went back to India or Egypt after 5 years, 6 years, 10 years, maybe from the first immigration, from the landing. But this is different. This group is different. Will be different.
Omar, I think it will at least give a trend. Since I am practicing in Kerala, where I see a lot of people who are coming from Gulf, and I have noticed that the second generation of Gulf people, they have got a slightly increased risk of or having increased number of IBD. So even my observation is that. So I think your study will be very good, and I think if everybody can collaborate on that, and especially in Gulf countries, I think that will be a very good thing. That will give some idea about the expatriates versus the national. Are they a number of years staying together? Is it becoming more equal to nationals? May not be as equal to that of that as in Western countries, but there will be a trend. We will understand the trend of what is happening. Usha, can we?
Go to the next study, Usha. That's your study.
Okay, no, I just wanted to make a small comment here, because in Chandigarh, with Punjab being very close by, we get a lot of people going up and down to Canada. So that is another area which we can contribute in.
Okay.
So the
Usha, I think you can come back to your study now.
Yes.
Sure. Partha.
Yes, sir. Yes. The fourth proposal is vitamin D deficiency in IBD, prevalence and relation to disease activity, severity and extent, a cross-sectional multi-center study. The aim of the study is to study the prevalence of vitamin D deficiency in IBD, relation to disease activity, severity, extent and duration, and assess the risk factors of deficiency like sunlight, diet, vitamin D binding protein loss, nutritional status, and different clinical features will be assessed. All IBD patients of 12 to 70 years can be included in that, and these are the basic things that need to be collected for the study. That is the extent of disease based on Montreal classification, disease duration, frequency of severe episodes, severity based on symptoms, simple colitis activity index and Harvey-Bradshaw index, and endoscopic severity as per standardized scores. Also Roberts histological index for histological activity, and composite severity scores like CDI and UCDI scores, and inflammatory markers such as fecal calprotectin and CRP. And the investigation that has to be done are complete hemogram, LFT, renal function test, CRP, ESR, cholesterol, vitamin D binding protein, 25 hydroxy vitamin D and 125 hydroxy vitamin D. 2 ml of sera is required for each for ELISA of these last three, and IPTH is ideal, although it needs immediate cold storage, so it is optional. And test, target and treat to see whether the correction of deficiency prevent further relapses can be studied further. So I keep this open for discussion.
Can I just add here one thing?
Yes, ma'am.
Can I share a screen? Is
yes,
that
yes, yes.
Yeah, so is the screen being shared? Yeah. So here what I have done is, sorry. Yeah. Oh, 1 minute. Yeah. So here I've made a Google form. It's a very simple Google form in which we get the basic demographics of the patients, and then we have the inclusion-exclusion criteria, and it automatically translates into an Excel sheet, and we have the disease extent by Montreal classification. No, there aren't very many questions. These are the standard stuff which we anyway take in our course of diseases. The first episode, relapsing, remitting. What is the severity of the disease? Are there any complications? And what are the extraintestinal manifestation? Age of onset, duration of disease, their socioeconomic status, their BMI. So this will link up with the nutrition study also. What is their present stool frequency, blood endoscopy? So all this is there, and already the website, you know, all the data. So to that, I have just added a section on sunlight exposure. It tells us their race as well as the place of residence. Later on, we can calculate the latitude of that place and the amount of sun exposure they take in summer and winter, and which part of their body remains exposed. And apart from this, if they go to any tanning center, and food intake in terms of milk intake, in terms of their dairy product intake, in terms of their fish intake, because these are the three main sources of vitamin D, and if they are taking any supplements. After this, we basically have whether they're taking any supplements, any clinical features of vitamin D in the form of any bone pains or muscle twitching. This is not necessary. I think we can drop this component, and we can just measure their serum levels of vitamin D. The simple way is we just take a sera and keep it in -20 or -80 and run an ELISA at the end of the thing. And if we can send ELISA kits to them, I can organize that for them. And their cholesterol level at that point of time, CRP, ESR, and fecal calprotectin. I think most of our labs have this. And we can study vitamin D binding protein levels, because this will be very unique. There are no studies in international literature which have looked at vitamin D binding protein and vitamin D levels. So that will add the uniqueness and novelty to the study, because in patients with protein losing state because of severe UC or Crohn's, the vitamin D binding protein is lost in the stool, so we can get a correlation there. And the other component of the study is test and treat to target component. This, if I can just show you one slide in this. We have discussed last time all about vitamin D, how I'll just open up this one slide for everybody. What we found is that in those people who reached the vitamin D level of 40, they were the ones in whom there was significant reduction in disease activity. So this will be a very useful thing to take it further and see whether if we treat patients to a particular target of 40, maybe we will reduce their disease activity, improve their quality of life, as well as reduce their relapses. So as such a large study, so not only can we look at the prevalence in these patients of vitamin D deficiency, we can also look at its relationship to disease activity. We can see the risk factors and study the effect of supplementation. So this component is very useful. We found it in our set of patients to be very useful, and which can be extended across, and it will be a simple low-cost measure to improve the quality of life of our patients. So I will not go into all these details.
Yes. So I think, Usha, this study is really going to be very useful for the region, I feel. I think, and the Google Forms are very good. We are, I also take this opportunity to tell everyone that, you know, our program, the Zoom link is for us members, and we are now live on our website as well. So if people go into the current initiatives page, they can click there and see the program live. So this is the first time we are having a live program on our web page. So it's big that way. We'll try to see whether these forms can be incorporated in the registry, or else we can circulate it separately as well. So for everyone who's listening, I think we will circulate once again for those who did not reply. I think most of the members have replied, but we have now got a larger number of members and new members. So we will circulate once again. And then for individual studies, we will have closed group meetings, so such that the matters can be thrashed out in a better way.
Rupa and Usha,
yeah.
Usha, it is a wonderful study, very simple and a very elegant study. But I would like to know that if you take a parameter of 40 and above, and you are also treating the patient, so actually whether it is a confounding factor or something, because there are many other factors involved in that other than vitamin D alone. Of course, you know that the nutritional standards improve, and because I am a person who does vitamin D for every patient, and almost all the patients who are deficient are on treatment.
Yeah, if I can just show you this slide, vitamin D levels we assess. If it is more than 40, we just give them 60,000 units once a month. In those who are deficient, that is less than 40 nanograms per deciliter, we give them weekly for 8 weeks or 10 weeks, and then we maintain their vitamin D at more than 40. So at 8 weeks, we can assess whether they have reached the target of 40. The reason I'm saying 40 is that the immunological effects of vitamin D comes at 40. The bone effects comes at 32. So our target level should be higher, because the other thing which I find is patient with severe UC, if you keep giving them vitamin D, it is lost in the stool. So you have to, give a little more, just like how infliximab is lost in the stool of patients who are having active IBD. So similarly, my aim here is that all patients should be tested. We should treat those who are deficient, and when we treat, we should again reassess their vitamin D level to know that we have reached a target. So that is the 3 key component of it.
Thank you, Usha. Any other quick comments? Actually, we are running short of time.
Just one quick comment. Why not patients from 7 years onwards? I know less than 6, we have VEO, IBD, it's a different subgroup. But why not from patients from 7 years onwards? Why the patients only from 12 years onwards?
No, we can do that. I'm an adult physician. I'm happy for pediatric people to also join in.
Thank you.
Rupa?
Yeah. We'll go to the next one. Just a quick one. I think Tan is there. Tan, you wanted to participate in the vitamin D study. Am I right?
Sorry. Yes. Yes, I'm interested in. But the problem is the previous protocol show we need some sophisticated investigation like
yes, that's why I thought. I think Usha has made it much more simple. So yes, I think this is very achievable.
That's only for vitamin D is okay for us.
Yes. Okay, Tantan. So we'll go to the next project, Dr. Philip.
Yeah, I think, Partha, you
yes, sir, yes. So the fifth project is from Bangladesh by Professor Masoodur Rahman on prevalence and risk factors of GI infections among patients with active ulcerative colitis. The aim of the study is to assess the frequency of bacterial and fungal infection in active ulcerative colitis versus those in remission, identify different organisms and risk factors and outcomes of such infections. Simple indexes and demographics, details of hospitalization and treatment, and as well as past history will be taken. And simple tests like stool microscopy, stool culture or PCR for stool Clostridium difficile toxin would be assessed in this. So I'll also show the proforma. So Dr. Masoodur has shared with us the proforma for this. So this is the simple clinical colitis index, then the hospital name, patient demographic details, and then the diagnostic criteria. You see disease location, manifestations, systemic and local treatments, antibiotics, history of surgery, and stool microscopy for trophozoite cysts, stool culture results, stool Clostridium difficile PCR results, and these are the severity classification, mild, moderate, severe. So, and this is the clinical scoring system, the SCCAI. This is about the study. So, this project is open for discussion now.
First, your comments, Dr. Masood.
Thank you, Rupa.
Yeah.
So, in fact, this will be studied to see the frequency of bacterial infections that will include clostridial infections as well as non-clostridial bacterial infections, and second one is the parasites. So what we will do, we will do the stool microscopy for 3 times and conventional stool culture. So see the Campylobacter, Salmonella and Shigella. And the third thing we will do Clostridium difficile toxin assay by PCR. So these are the 3 investigations we are planning to do. So the objective is again to see the frequency of infection. Second one is to see the risk factors of infections, and third one is the outcome of infections in terms of hospitalizations, length of hospital stay, rate for colectomy, and duration of hospitalizations. Rupa.
The infections, you are looking only at the bacterial infections and parasites, or you are looking at the viral infections like CMV and all?
No, due to budgetary and other constraints, in fact, we have proposed only stool microscopy and bacterial cultures. We can do that, but that will require a lot of, huge amount of money, and it may not be possible to participate to all other centers. So to increase the participations from many centers, from many countries, we have tried to keep it simple. But again, it is a matter of discussions that we can make it more simple, or we can make it more advanced or more complicated.
Usha.
Yeah, I have a question. I have an assessment of a pattern of what's happening. All centers need some basic data about patients with IBD, which comprises 80% of the data that each of these projects need. Another 20% of data can come from stored sera, can come from stored stool, and some may require active investigation on site. So the ones in which we have stored sera and stored stool sample, in those with a standard proforma, which will cover 90% of the study material that we need. So if we just make one single proforma for all our patients and add one additional page component for each of these additional studies, with a stored sera and stored stool, I think our job will be done in 90% of the projects.
I think Usha, what I'll do is I'll take all the proformas that we have, we'll combine the first part of it and then add the second as supplement. So to participate in can do the supplement page. I think it's a good idea. I think from Vietnam, has anybody?
Rupa, I have a comment.
Yeah.
Yeah, regarding the transfer of the biological sample, particularly the stool, sera, and other things, there is restrictions in different countries. So it is not so easy to transfer from one country to another country, and this has become more complicated and more difficult during the COVID era.
Very important point you have made. What I was saying is each center stores the stool, stores the sera. Kits can be sent across to those centers so that they can run their own ELISA or their specialized tests there.
No, but only problem I'll tell you, actually you have to take, I think your suggestion of having a common proforma and adding supplemental proforma is good. And that will be the practical way of doing this. But as far as the storage is concerned, when we are talking about stool microscopy, let us see in this project, or culture, it should not be stored. Because in a stored sample, you will not have good good data. Second thing, when it comes to any DNA-based test, yes, you can store, but then, Rupa, you should have a proforma and send to all the centers what facility do they have for storage. Do they have -40? Do they have -80? I believe that some of the center, particularly those centers where their hardcore research is not going on, whom we want to be very inclusive of them. There, I think the storage will have a lot of issues. And second thing also, when you talk about the DNA-based studies and all, only sending kit will not work. Let us say they send DNA extraction kit, you send primer. What happens is they require expertise. So, and also the uniformity will not be there. If there is not lack of adequate expertise, which I suspect even Bangladesh will have. Sorry if you want to differ, Masood, you can differ. But in Bangladesh, if you have to do a lot of molecular tests, you can't go to Dhaka Medical College. You have to go to ICBDR. And ICBDR's ethics system is very restricted. They will ask where from the fund is coming. They will not be happy with kids. Am I right, Masood, or wrong?
Yeah, I am not in Dhaka Medical College now. Now I'm working in the Sheikh Hassan National. Yes, you are right. You are right.
I know you are now in Sheikh Abdul, but I get an exam.
Yes, you are right. You are right. In some cases, they will ask for the fundings and other things because we cannot do all the tests from the patients. So the ethical committee will ask all these issues. Particularly, the ethical issues are very strict at ICD as you mentioned.
If I can make a comment, can I make a comment, please?
Yeah. Carry on.
I think Professor Ghoshal is very right. Storing the stool will not be appropriate for for bacterial culture and for protozoas. So that's no good. But for the study of the DNA-based studies, actually, if the facilities are there, of course anybody can do it. But these are going to be quite expensive. In Dhaka, of course, we can get them done, but the funding will have to be quite substantial, I think. And I doubt whether the countries that we want to include in this study, all of them will have this facility. I doubt that. And storing that material in the fridges, various centers, and conducting this study later on is Professor Ghoshal has rightly said, it's unlikely to be uniform and unlikely to be very informative. So unless we have got a very good fund, we would rather stick with the very simple study.
Thank you for your comments.
Thank you.
Rupa, Usha.
Yeah, my comment is that we should focus on simple, large studies which are based on simple stored sera or situations in which we can just store the stool sample and say do calprotectin later on if they don't have an active calprotectin.
I think we would like to follow several of them. Which one doable in our center? I think nutrition, study of nutrition and vitamin D and infection from Masudur quite doable. So I think we will like to follow all this study. Instead of we are proposing a new proposal. And concerning the ethical clearance, I think we can arrange our local ethical clearance for all those studies, and I think it would not be a problem.
Yeah,
Thanks
for that. I just noticed because of my things are off, we can't see all the time. But Bach Mai Hospital in Vietnam is any. I find it difficult to pronounce the names. Dr. Hilmi Sway is here, but I think Nguyen Thi Tu Hien.
Hilmi Sway is from Myanmar, Rupa.
Yeah, Nguyen Thi Tu Hien or Rui Tang Ung.
I'm from Malaysia.
Oh, okay.
All right, thanks.
Hi. So your comments on this thing, on this study? Infections?
I think we do have a lot of, we do intermittently have some infections. I think, I think I have not much comments on that. Yeah, so yes, the experience in this area is quite limited. Yeah, I have not much comment on that. Sorry. Yeah.
Okay. So if Dr. Ahmed Zaid, I'm just seeing now actually on my phone from Egypt.
Rupa?
Yes, so nice to see you. We were looking for you in the study by Professor Omar. So I thought we'll have your comments on the projects.
Okay, actually, I think it's a very good project of Professor Mahmoud Omar, and I can communicate with him to do if there is any extension for our work in the Egyptian patients in Egypt.
Yes, I think you can do that as well.
And actually, I am linked to the other project of vitamin D and IBD, and I think it is very simple, very easy. It will be add a big value for us.
Okay. Thank you.
Thank you.
You have the last project, sir.
I know that. So, what is the agenda now? Ruba, winding up? Any comments?
The last project is just the mental health project. And I think we just need a few quick comments because all the stalwarts are here. Usha, Dr. Uday, Dr. Desai.
So,
Dr. Chetan Bhatt is here. Sir, need your comments on this one.
Rupa, I have one question. Probably it was discussed earlier. So, do you need to translate and validate the psychological questionnaire and the quality of life questionnaire in different languages?
Yeah,
yes.
Should I discuss this one? So we have. So this is on the project 6 is on evaluation of psychosocial impact of IBD in patients and caregivers. We have now included the caregivers in the project in the developing world and IBD emerging nations consortium initiative. The objective of the study would be to assess the prevalence of mental health illness, that is anxiety, depression and stress. These three will consider in IBD patient based on DAS questionnaire.
The thing that we thought was this, that everybody focuses on the patient. So in this, we will also focus on the primary caregiver. So because that is overall impacting the quality of life. So not only the patient, but also the caregiver. And I agree, Dr. Masood, we'll have to translate it. We are in the process to do it in
but it can be assisted questionnaire survey can be done. If some research assistant is there, then she can.
So I want your opinion. If can we do an assisted?
I'll show the questions. They're actually very easy. So yeah. So and the next step is to assess the risk factors that we will do by regression and analysis, like different demographic factors, and to evaluate the effect of mental health illness with quality of life. That will assess by short inflammatory bowel disease questionnaire and IBD disease severe activity by composite scores like CDI And psychosocial and optional is psychosocial intervention in those patients that some center may not do. And also assess the caregiver burden in primary caregiver of the IBD patients. That is unique for the study. And to identify the risk factors of high caregiver burden by seeing the socioeconomic status and other demographic factors, and assess its effects on quality of life and coping strategies. So questionnaires for IBD patients, the basic part, yes, it is visible. So apart from the basic demographic questionnaires and disease detail questionnaires, we will have this -21 questionnaire, which is for screening anxiety, depression, and stress, and also the composite disease questionnaires, SIBDQ for quality of life, and COPE questionnaires, that is 14 questions, 7 for adaptive and 7 for maladaptive coping strategies, and social constraint questionnaire, 6 questionnaires for with the friends and 6 with the partner or the spouse, and Morisky medication adherence scale for assessing medication adherence. We can correlate this different quality of life with medication adherence, or if we get the scores, we can make a correlation between them. Questionnaires for the caregivers, demographic history, total household income, and the standardized caregiver for assessing the caregiver burden is varied burden interview. If the score is more than 21, that means high caregiver burden. Additionally, we can assess the quality of life of the caregiver, but we can omit that also. And similarly, brief COPE survey can be done for the caregiver as well for different coping mechanism. I'll just show the questionnaire one. So this is the first -21 questionnaire, by what we will diagnose depression, screen for depression, anxiety, or stress. And this is the brief IBD COPE questionnaire for seeing the coping strategy in the IBD patients. Total constraint questionnaire, 6 for with the friends and 6 with the spouse or friends. Who are unmarried, we will include only 6 questions. This is the Morisky medication adherence scale, 8 questions are there. Varied burden interview for the caregiver, assessing the caregiver burden. If it is more than 21, high caregiver burden is present. Actually, questions are very simple. So only no tests and no investigations are actually needed for this, but little bit of your time or some research assistant, you have to only 10 patients, 5 to 10 patients from each center will also be enough, because there is no data from this part of the world.
10 patients per center, and there is no such data on caregiver across the globe. Only it is very less.
For pediatric IBD, there are separate validated questionnaires. I have not included them, but that can also be done. There are several studies actually more in the pediatric IBD group in the literature.
Rupa.
Yes.
But I think it's actually a very good study, and it's very seldom studied also, and from the patient aspect is quite relevant. And regarding the caregivers, who should be targeted? You will treat the primary care physician.
Primary caregiver.
The primary caregiver, in the sense that the spouse or the leading member who's taking care of the patient.
Basically, the parents, no?
The parents or the wife or the husband or whoever is the primary caregiver.
Okay.
Rupa, Dr. Chetan Bhatt here.
Yes, sir.
See, this is a very good study, and unfortunately, this part of the IBD is not visited very much. There are very few references on this. It is very extensively studied in IBS, but not in IBD. We have a postgraduate student in our institute, so Dr. Harshad Joshi and me, as with a PG student, we are already doing this project. The psychosocial part, psychiatric comorbidities and IBD, and how does the treatment of the psychiatric comorbidity with the help of psychiatrists and also we also give, and how it is changing the outcome in IBD. We are already doing this study, and our PG student has already started doing 1 year back. So it will be very great to be part of this study, and it will be a very exciting study.
Thank you. Yes, Usha?
Yeah, excellent thought, Rupa, that we have to assess on caregivers. That will really make it unique. There are a lot of studies on IBD patients, and there is a very good questionnaire by short IBD questionnaire on quality of life by McMaster, which is a validated questionnaire.
Yeah, we have included that actually, Usha.
Yeah, so recently I had downloaded it for one of our studies. It is at a minimal cost of $75. And when you have more than 500 patients, the rate is lower. So we can easily take that questionnaire because that is one of the most validated questionnaire. We can do just that for the patients and we do one for the caregivers.
Yes.
Because if you make it very bulky, then the quality of data will go down.
Yes.
So out of all your questionnaires, since anxiety, depression has very much been already assessed in IBD patients, let us look at the quality of life of the patient using the McMaster questionnaire and look at the quality of life of the caregiver.
Yes.
So just these two components should be unique and would be useful.
Yes, I agree. I think we'll simplify it and then we'll circulate. We are trying to get it translated to Hindi, but for majority of countries, many countries have actually not agreed to do this paper because of the translation issues. So,
and also one point, there is a financial burden also. Even a simple tablet like mesalamine, OD preparations, 1 TDS or 2 TDS for 1 month is a lot of financial stress on a middle class family. So the caregiver also is stressed out, if there is a financial constraint. There's a very good study for caregivers also if you include it. Very nice study.
Yes, I agree with you, Dr. Chetan. Extremely interesting to look at it from a caregiver's point of view, and financial constraints changes their quality of life also, and they can't eat out so often. There are various issues, especially with the spouse. So that will be useful.
Yeah, I think any more comments?
Jayanti has mentioned that Duke's questionnaire, it is quite simple from that.
Okay. Okay, so we will try to take these points. We'll make these changes.
Actually, we discussed with our psychiatrist, and he told that this DASH21 actually we can diagnose both depression, anxiety, and stress. All of these three are the main components. So, as a screening tool, we can use this.
Yeah,
although there are multiple questions.
So our psychiatrist suggested this.
This has a good sensitivity and specificity.
Yeah, so good sensitivity, specificity, many psychiatric papers on that. That's why we chose it. But I agree with Usha that we have to make it simple. So we'll go through the questionnaire, circulate it amongst everybody, and then take it forward. But this is simple to go, no money needed major.
Absolutely.
And will be useful. So we'll do that.
Yeah. So, Rupa?
Yes. So good discussion today, and to wind up everything, I'm very, very happy that Dr. G.N. Ramesh will be able to join us. Dr. Ramesh.
Yeah,
remember Dr. Ramesh did yes, wonderful to see you, Dr. Ramesh.
Yeah, I've been sort of a silent spectator, but I've made a few points here. First of all, Rupa, I think your presentation brought a smile on my face, because 3 months back, we were literally zero when we started with a clean slate. And today we are in the midst, in a position where we are discussing at least 10 or 15 potential projects and studies. And that is something which is a huge achievement. And that's why I said your presentation did bring a smile on my face. Now, the thing is, I think the inclusion of pediatricians into this group has actually brought in a totally different, new angle. And I think that is where a lot of excitement lies. There is a lot of potential in collaborative exercise between the pediatric IBD specialists or experts, as we call it. And I think it is time that we all sit together, come out with at least 3 or 4 good, interesting projects in pediatric IBD, where people can pitch in and get their data together. I think that will add a lot of excitement. That's why I believe that pediatric IBD is one area or angle of this IBD ENC, which to me appears to be very, very, very exciting. We've discussed about at least 12 potential projects. I had mentioned in privacy to Dr. Rupa earlier that I think it is now important that one of us takes up leadership in a particular project and starts steering that particular project in that direction. Discussions can go on, ethics committee, all those things will go on, but I think the next step has to be ownership and leadership for each project. And once you assign the ownership and leadership for each project, then you will see that in 2 to 3 months' time, you will be able to develop a good database as well as good material, which can be the basis for further studies. I think there's a tremendous future. Discussion led by Mathew Philip and Ida has been tremendous. There's a lot of positivity in this, and I think the next step has to be ownership and leadership. And this is where I think we must concentrate. Thank you very much, Bishop.
Thank you. Dr. Ramesh, you are always so good in, making a summary that there's nothing much left to say after that. Is Dr. Philip?
I am there.
Yes, Dr. Philip, your comments and we will end today. But I will, before ending and before Dr. Philip, I'll say thank you so much. We will meet in person. We will have IBD ENC. We will have it in different countries. And once we meet in person, then, you don't have to look at the screen to see whose screen is popping up and whether we can have comments. But this is the way to go right now. I'm so happy that all of you have joined. Our web page also, many people, YouTube, our Facebook, Twitter account is now active. But we need all of your help to make all of that more active. Please comment on the cases in the IBD ENC platform. Please ask all your members, all your colleagues to become members so that they benefit and we get more comments. Send in your papers, all that you have written in any journal. We will publish it. We will put it up in the website such that our work is highlighted, not only the Western data. Having said that, thank you once again. A very big thank you. Quick comments from Dr. Usha and then Dr. Mathew Philip.
Usha, are you there?
Yeah. Rupa, I can volunteer to look at all the proformas you have received so that we make one composite proforma for all the studies and then additional pages so that we can, start off from there.
Yes, that will be very great. Thank you, Usha.
Thank you, Rupa. Thank you, Usha. Thanks, GN Ramesh, for the wonderful comments and crisp and sharp comments on that. And all the members who have logged in from different countries and introduction of pediatric group into this study and this group consortium. And I have seen many enthusiastic pediatric gastroenterologists already made their comments. I can see Maya Pidambaran there, and she is also very active in IBD. So I think it was a wonderful meeting. I think next meeting we'll join. Say bye and take care. Stay blessed. And
so next meeting next year.
Next year. Okay.
That will be a COVID-free year.
Okay then. Wonderful.
All the best.
Thank you.
All the
Thank
best.
you,
Take
everyone.
care.
Thank you.
Thank you. Bye.
Everybody.
Thank you. And bye.